Hi, good evening, everyone. Welcome to the week 6 of Medicinal Chemistry. I'm your TA Gitanjali Singh, a PMRF Fellow from Department of Chemistry at IIT Kanpur. Let's start the session today. This session is held every Monday from 6 p.m. to 8 p.m. This is the same link. It will be valid for the upcoming 6 more weeks. Today, during this session, we'll discuss last week's summary, last week assignment, that is week 5 assignment, some modular questions just to give you an idea of how to solve the upcoming week's assignment, and yeah, that would be it. In case of network disruption, please wait for a few more minutes. If that's from my side, I'll try to join back as soon as possible with the same link. If you have any questions, please post your questions in the chat box during the session. This session is recorded, and the recording of this session will be shared with you soon. Um, I hope I'm audible. I'll just assume that I am. In the sixth week, the topics that were discussed were pharmacokinetics part 1, 2, drug metabolism 1, 2, 3, and 4. There were various aspects of drug metabolism and pharmacokinetics discussed. We'll discuss all these very briefly and get directly to the question solving. Pharmacokinetics and pharmacodynamics, these two are very confusing terms. Let's discuss this properly. Pharmacokinetics, pharma means drug and kinetics mean movement. This is basically what the body does to the drug. Pharmacokinetics focus on how the body affects a drug. It involves ADME, absorption, distribution, metabolism, and excretion. It examines the drug's journey throughout the body from the absorption into the bloodstream to its elimination. It involves measurement like absorption rate, bioavailability, half-life, and clearance. All of these terms we'll discuss thoroughly in the upcoming slides. Pharmacodynamics, again, pharma means drug and dynamics means power. It's what the drug does to our body. It's a study of biochemical physiological effect of a drug and their mechanism of action at organ, subcellular levels or macrocellular levels. Pharmacodynamics deals with how a body affects the drug affects the body, including its mechanism of action and resulting physiological effects. It represents the number of atoms in a particular element within a molecule, obviously, and the parameters involved are efficacy, potency, and dose response relationship. We'll discuss pharmacodynamics in next sessions, but today our focus will be on pharmacokinetics. You can see in the right side we have written pharmacokinetics. So it starts when the medicine is administered. So the medicine goes into plasma via the process of absorption. That's called input. Once the medicine goes to the plasma, it's distributed to the circulatory system. Uh, Again, that's medicine and tissue. The third part is metabolism. In metabolism, the drug is broken down into metabolites that are more or less inactive form of drugs, and then it's excreted out of the body. So, absorption into circulation that we discussed. There are various ways in which this absorption happens. How the body is administered. So the first, a drug requires a method of absorption. often known as the route of administration. Then, that is for absorption. Then it must be absorbed into circulation and distributed to various parts of the bodies, where it is basically third now. After distribution comes to the third part, metabolism. Now, uh, in metabolism, it is metabolized or broken down, obviously. And once that happens, it becomes a metabolite, its work is done. Finally, we want it excreted from our body and finally eliminated from the body. So ADME. Talking about absorption, I talked about routes of administration. Now they are divided into three parts. Enteral, you can see it as like, you know yeah. So in today's world, medicines are available in various types, like uh, in forms of tablets, capsules, suspensions, ointment, you know uh, in vaporous forms as well, or maybe in some cases sustained delivery of a particular preparation. So uh, before talking about internal and local applications, let's talk about systemic and local effect. Now, systemic effect is the effect produced by a drug after being effectively absorbed in the bloodstream, whereas local effect is the effect produced by the drug in a localized area where it is applied or administered. For systemic effect of a drug, the possible routes of drug entry in the body may be divided into two main classes. You can see enteral and parenteral. Now, par means beyond, enteral means the gastrointestinal intestinal tract. So enteron, there's that's a term where it comes from, enteron. We directly refer to GIT. Now, for systemic effect, we talked about that. Yeah, the term and enteral, yeah, GIT and parenteral, that's beyond GIT, and local application, it's for local effect. So now let's talk about the enteral. There can be three types of enteral administration. The first one is oral, the second one is sublingual, the third one is enema. Now, wait. I'm sorry. Yeah. So, oral is when you take the drug directly. The drug is taken in mouth and then swallowed. Sublingual is when the drug is kept in between, you know, under your tongue. That's called sublingual. Enema is when the drug is administered to the rectum via your anus. That's how enema is given to anyone. Now, advantages of oral administration. It's obviously preferred route, and it does not require any specialized skill. There is no need of sterilization. But the disadvantage is not every drug can be taken orally. Obviously, the drug that undergoes degradation after, because once you have a drug, once you take a drug orally, it goes via the your esophagus to stomach, and our stomach has hydrochloric acid, where where these drugs are hydrolyzed and broken into pieces, they degrade basically. So they do not reach their uh, site of action. And also it cannot be given to kids or unwilling or non-cooperative, yeah, non-cooperative would be a better word, non-cooperative patients. It cannot be given to unconscious patients as well. And there are certain drugs like insulin and testosterone that are like destroyed before insulin. Let's talk about insulin gets degraded before reaching its site of action, and it's degraded in GIT, whereas in testosterone, it's destroyed many times, and it delays the onset and takes 3-4 hours. In sublingual, again, sublingual, that's under your tongue, the absorption is very fast. Obviously, it's active medicine gets absorbed directly into the systemic circulation. Ephedrine hydrochloride tablet is administered for this in case of asthma, where you like immediate, where you want to see like immediate uh, relief, immediate action. Even in case of angina, angina pectoris, yeah, angina pectoris, the drug is administered sublingually. Yeah, nitroglycine for angina pectoris is, given sublingually. Now, the disadvantage of this kind of route of administration is, if a drug has some toxic effect, it should not be given directly because it goes directly into systemic circulation. So we cannot have any drug so that has like some toxic effects. We want obviously the drug to work fast, but we don't want the toxicity to affect us either. In case of anemia, the drug is administered in the rectum through anus. There's other several types of anemia as well, but we'll not go into that details. It's generally done before X-ray or surgery or colonoscopy. Now, by enteral, that is beyond enteral. That's routes of drug delivery other than the alimentary tract. They are injection, they can be done via injections or inhalation. Now there are certain different ways of injecting a person or injecting anyone in that case: intradermal, subcutaneous, intramuscular, intravenous, intraarterial, intrathecal, and intramedullary, and intraarticular. Sorry, is there anyone writing anything? uh, if you have any question, please unmute yourself. I'm not using my ipad to I'm not using the screen share from my ipad today, so I won't be able to check in the chat box very regularly. If you have any important question that you want to be addressed at that point, please unmute yourself and just ask it. So we were talking about injections. Now, depending on where and how they are administered, there are several types of injections. Intradermal, uh, they're basically injected in the layer of the skin. Like in case if you want to see whether a person is allergic to penicillin or not, the a small dose of penicillin is, yeah, injected to person to observe the allergic reactions. And in some cases, vaccines, most of the vaccines like BCG and smallpox, they are given intradermally. Now, um, you know uh, subcutaneous is below the skin, and intramuscular is in the muscle. Intravenous, this is important. It's quite useful to administer irritant or hypertonic solution. I'm sorry, there's something wrong with my, yeah. But drugs with oily vehicles, or there are some drugs there. I don't know if you know about liposomes. So people are trying to formulate some vaccines with liposomes, and they're basically lipid vesicles, just to protect the hydrophobic constituent of the vaccine in the lipid vesicle. Now, things like that, they cannot be given intravenously. Drugs with oily vehicles and those that can precipitate or coagulate the drug should not be given intravenously. Intramuscular includes, um, intramuscular is when the drug is given directly to the muscle. Includes soluble substances, mild irritants, suspensions or colloids. The absorption in intramuscular injections, they are quite uniform, and even insoluble, not insoluble per se, but yeah, mildly insoluble, and oily bases can also be administered via intramuscular injections. Intraarterial, when the blood when the injection is given directly into artery. Intrathecal is for uh, when you want to inject something into the spinal cord or something like that. Intramedullary, even in medulla. And intraarticular, again, as the name suggests. Inhalation is for those kind of drugs that can be inhaled, like in vapor form. So yeah, local applications include ointment, move or something, you just spray there, and you see the local effect of it, not systemic. So local applications. Now, after the routes of drug administration, let's discuss passive and active transports of drug. Now, there are two types of passive transports as well. You can see in the diagram. I'm sorry, passive diffusion and facilitated diffusion. You know, um, it goes from when we talk about diffusion, the one thing is very clear. It goes from high concentration gradient to the lower concentration gradient. So it travels from where the concentration of that drug is high to the place where it's low. So that's how most of the things go. So yeah, it does not require energy. Generally, small molecules that are lipophilic, they travel in passive distribution. Facilitated diffusion is, water soluble drugs that pass through porins. That's facilitated diffusion. The important thing to note here is, in this case, in passive transport, there is no ATP involved. In case of active transport, however, there is ATP involved because it goes against the gradient. So here, um, the transport is against the concentration gradient. ATP is required. There are specific carrier proteins that require ATP to move drug from into the cell, and sometimes molecules are so large that they require endocytosis. So endocytosis, you can see here, basically, in which they are engulfed by plasma and kept in vesicle form and absorbed into the body. So that's endocytosis. We discussed endocytosis in our last class as well. But yeah, that's basically endocytosis. Now, absorption varies among different individuals, and there are drug related factors like influence, rate of absorptions, that basically, so not everyone absorbs any particular drug in the same way. So there are various ways, various factors that influence our the absorption, such as molecular weight, pH of the environment, the formulation, the surface area, blood flow, and solubility. The small non-ionized lipophilic molecules can pass very easily through plasma membrane with just passive diffusion. Polar molecules, however, they are difficult to pass through membranes, and this is how it's decided how the molecule gets absorbed, and that's where the bioavailability comes. Bioavailability refers to the extent and rate at which the active moiety enters the systemic circulation, thereby assessing the site of action. So basically, uh, the fraction of administered dose of a drug that is unchanged when it enters the systemic circulation. So, um, let's say if just a minute. Oh, isn't my screen visible to anyone? I'm sorry. I didn't realize it. I'm so sorry. Just a minute. I'm so sorry. Can you see the screen now? I'm so sorry. I didn't realize that. My screen is visible right now. Should I continue? Shall I continue now? Okay, perfect. Please, sometimes I'm unable to check the chat box. If that's the case, please unmute yourself and let me know. I'm so sorry. I'll try to check the chat box frequently now. So, bioavailability, the fraction of administered dose of a drug that is unchanged when it enters the systemic circulation. So, suppose that you're given a drug, you took a drug, and say you that was like 20 mg and 20 mg of the drug, and 20 mg of that drug was available to the body. That means, the 100%. So 20 mg was taken, and at the site of reaction in systemic circulation, you got 20 mg of the drug. So that's 100% available, sorry. But if it's just 10 mg, then it's 50%. You understand, right? So yeah, I am in case of intravenous injection, the bioavailability is 100%, because you know in oral route of administration, most of the things are metabolized on their way before reaching the target, whereas in case of IV, because it is directly injected to the venous, I mean our veins, they are 100% bioavailable. This is called first pass effect, which refers to the mechanism by which most of the drugs are converted into inactive metabolized prior to entering the bloodstream. This first pass effect makes the drug more bio unavailable. I mean, it decreases the bioavailability of the drug. So as you can see from the slide here, The bioavailability is the fraction absorbed into systemic circulation. Again, this is the GI lumen, and at every point there is some part of it that's that's exiting. You can see this GI wall, GI lumen, and then portal vein, and finally to liver, where most of the metabolism, the main site of metabolism is liver, and you know, and then it goes into systemic circulation. Bioavailability can be calculated by area under curve. You see here, this is for oral administration, and that's in case of this particular medicine, propranolol. So this is for bioavailability, and the area under curve for oral administration as well, and this is for in case of IV. When you calculate BA, you calculate area under curve for the in case of oral administration by AUC under IV into 100. You can see here this purple one is for intramuscular, and this pink one is for intravenous. You can see the intravenous is so much bioavailable at this point, and then for intramuscular and sublingual, oral tablet and oral capsule, as they have to pass through you know more stages of metabolism, they become less and less and less bioavailable. I hope I was able to explain this term. If not, while solving the questions, uh, I've tried to incorporate many questions on bioavailability. So if you don't understand it now, hopefully while solving the questions, you'll understand it better. Now, let's discuss a little bit about distribution. So, distribution is the process by which drug spreads throughout the body tissue and the blood. It's the second stage of pharmacokinetics after absorption, which is the study of how drug moves through the body. There are several factors affecting distribution, as drug properties, membrane permeability, lipophilicity, molecular size, and plasma protein binding. So, say if a few of the drugs are more membrane permeable, it's easier for them to travel and get distributed throughout the body. We are not talking about metabolism at this point. We'll talk more about it in upcoming slides, but at this point we are just concerned about distribution. And because we know it's easier for lipophilic substances to travel throughout the body, because of you know our body being mostly lipophilic, it's easier for them to travel. Molecular size, the smaller the size, it's easier for them to travel. And plasma protein binding, so if they bind less, they get distributed more easily. Let's start solving the question now. Which since we don't have many people here, I would encourage you to just unmute yourself and answer this, because that would be easy, and it would let me understand how it would make the class more interactive, if you don't mind. So the first question is, which of the following processes is not a part of pharmacokinetics? A. Absorption. B. Distribution. C. Metabolism. D. Pharmacodynamics. Yeah, perfect. So that's the correct answer, pharmacodynamics. Pharmacokinetics involves ADME, that's absorption, distribution, metabolism, and excretion. It describes how a drug moves in the body. Pharmacodynamics, whereas deals with the drug's effect on the body, and it includes its mechanism of action, efficacy, and toxicity. So pharmacodynamics is not a part of pharmacokinetics. Very good. The next question is, what is the major site of drug absorption in GI tract? That is gastrointestinal tract. A. Stomach, B. Small intestine, C. Large intestine, or D. Esophagus. Major site of drug absorption. You are right, but it's major site. Think about more surface area, you know, where does a main. Yeah, large intestine is for water absorption, um, but you're getting there. Yeah, that's a right way of thinking. But think about villi and microvilli. Now, it's actually option B. I'll tell you what. Small intestine, it's the is because stomach, obviously, the first option that you said was stomach, and it's actually quite close to the right answer because it has acid, and it actually degrades you know uh, most of the medicines. But small intestine has larger surface area due to villi and microvilli. It has higher vascularized epithelium, and because it's like uh, so convoluted, it has longer transit time than the stomach. And the pH condition is also favorable. In stomach, the condition is mainly acidic. It helps in drug dissolution, but absorption is mainly in small intestine. The large intestine absorbs water and some drugs, but it plays minor role in drug absorption. Is this clear? Yeah, yeah, perfect. Let's move to the next question. Which of the following best describes passive diffusion? A. A drug moves against the concentration gradient. B. Requires ATP energy. C. Occurs via specialized carrier proteins with ATP. Or D. Drug moves from high to low concentration without energy. Option D. No, it's passive diffusion. We discussed about passive diffusion and active diffusion. You see, best describes passive diffusion. The correct answer, yeah. No, it's okay. Yeah, so this is a very new concept, so it's okay. The correct answer is D. The drug moves from a high concentration to low concentration. Let's talk more about it. See, um, let's talk about the difference between passive and active transport. So in when it's passive, it's not being that involved, it happens on its own. So you see, most of the time in day or anything that you do without putting much of your energy into, it happens passively, right? So there is no amount of energy involved, and it travels from high concentration to low concentration. Imagine there is a class where there are like 100 students. So as soon as you hear recess bell, everyone wants to go from crowded area to a less crowded area, right? So that's more like passive transport. That is the normal tendency to go from higher concentration towards lower concentration without any energy. But when you put more energy into something, you have to force people to come into more crowded area, so that requires more energy. So just remember, when it's active, it takes energy. When it's passive, it does not take energy. Okay. So the correct answer is D. Drug moves from high concentration to low concentration without energy. And passive diffusion is the most common drug absorption mechanism, because obviously the drug concentration in the body is obviously less, and even in our bloodstream. So when we consume a drug, when a drug gets administered to the body, it moves from an area of higher concentration to lower concentration, and there is no energy required or carrier proteins. And lipophilic fat soluble drugs, they easily diffuse towards membrane, because our membrane is mostly uh, lipophilic. Let's go to the next question. The first pass effect occurs primarily in which organ? A. Stomach, B. Kidney, C. Liver, D. Lungs. Um, yes, um, liver is the main area of metabolism, but first pass effect. Uh, so, metabolism starts when the drug is administered. Think about the oral drug. The first pass effect we discussed, right? So it stops being converted into it. But your way of thinking is right. Uh, but it's actually correct. So, is the first pass effect refers to the extensive metabolism of orally administered drug before they reach systemic circulation. Oral drugs are absorbed in GI tract and transported via hepatic portal vein to liver. Yeah, I would like to add something here, because it's not mentioned in this question. There is another question that I've added in this slide. When it mentions oral capsules, then you have to be careful, because the metabolism of oral capsules starts from GI tract only. So in that case, stomach would be right answer. But yeah, because it's not specified here, you're perfectly right. The liver metabolizes many drugs, and most of the drugs actually, before they reach enter the systemic circulation, and it reduces the bioavailability. Drugs given via intravenous, sublingual, or rectal routes, that is when the concentration is not too high for rectal routes, they bypass this first pass effect. Now, next question. Which of the following factors increase drug bioavailability? A. For high first pass metabolism. B. Poor solubility. C. Slow gastric emptying. D. Lipophilicity. It's okay, it's okay. The correct answer is lipophilicity. So, bioavailability refers to the fraction of an administered drug that reaches systemic circulation. Right? Lipophilic drug cross cell membranes more easily, as it's very easy to for them to follow passive diffusion. Hence, they are absorbed more easily. The factors that decrease bioavailability is high first pass metabolism, number two, poor solubility, and three, drug instability in gastric acid. Now, so yeah, I'll explain phase one and phase two after this. So I hope you've been through the lesson. Um, Even if that's not the case, we'll discuss this. Which of the following is an example of phase one metabolism? A. Glucuronidation, B. Acetylation, C. Hydrolysis, D. Sulfation. Yeah, perfect. That's a correct answer. Phase one metabolism involves functionalization of functionalization reactions like oxidation, reduction, hydrolysis that introduces or exposes a functional group, that is like alcohol, OH, NH2, and COOH, to the drug. Like in case of cytochrome P450 enzymes, they mainly mediate oxidation reactions in the liver. Hydrolysis is a common phase one reaction in which they are broken into esters and amides. Phase two metabolism involves conjugation to make the drug more water soluble so that they are excreted more easily. Again, metabolic, I'll just go discuss this very briefly. Metabolic processes are categorized into phase one and phase two. Now, make a note of it that in many cases of drug, in many drug cases, there can be just phase one or just phase two, or sometimes even phase two comes before phase one. So this is not exactly the order in which they take place, but in some cases the orders can be reversed and they can be only phase one or only phase two. So phase one involves oxidation, reduction, hydrolysis. Phase two focuses more on conjugation, where it makes the metabolites more water soluble for easier excretion. Phase one is also known as functionalization reaction. It introduces or modify functional groups on the drug or xenobiotic molecule, via oxidation, reduction, or hydrolysis. Most important part of phase 1 metabolism is cytochrome P450, that's called P450 enzyme, also known as mixed function oxidases. Other enzymes include alcohol dehydrogenases, because obviously there is reduction going on, and hydrolysis because of hydrolysis, and monooxygenase for oxidation. The outcome is obviously because after phase one they become more polar, water soluble, but metabolites are still active. Cytochrome enzymes add oxygen atoms to the drug molecule, converting into more polar form, and they also add hydrogen, increasing you know polarity, and hydrolysis to split the water, like in case of esters and amide. In phase 2 metabolism, it results in a larger, more polar, and often inactive metabolites that are readily excreted from the body. In case addition of glucuronic acid, a sugar molecule, or sulfation, it adds SO4 to the drug metabolites, or acetylation or methylation, adding of like CH3CO, that's acetylation, and methylation is addition of methane group to the metabolite. So again, it makes the metabolites more easily excretable, like easier for us to excrete them. Now, question number 7. What is the main function of cytochrome P450? 450 enzymes. A. Hydrolysis of drugs. B. Oxidation and metabolism of drugs. C. Active transport of drugs. Or D. Protein synthesis. Yes, perfect. Oxidation and metabolism of drugs. It's responsible for the phase 1 metabolism, mainly through oxidation reaction. It helps convert lipophilic drugs into more polar metabolites for easier elimination. And um, cytochromes are most abundant enzymes in case of in phase 1 metabolism, and they metabolize almost 50% of the drugs. Next question. A prodrug is a drug that A. is inactive until metabolized, B. is excreted unchanged, C. binds to plasma proteins permanently, or D, cannot cross blood brain barrier. Yeah, so prodrugs are actually inactive unless, so before taking, they are inactive, and once they are metabolized, they become more active. So it's pro drug before becoming a drug, right? So just remember it like this, like pro drug before being converted into an active form. It's um, it's called pro drug. So there is an example. um, so you see, in so this is done to increase bioavailability, obviously. uh, so some drugs, even if they are very good, before reaching their site of action, they start getting metabolized by literally everywhere where they pass through. All the enzymes are constantly attacking them. So by making them pro drug, we make sure that they have something, they become active after some steps of metabolism. So this increases their bioavailability, and you know by the time they reach their target, we still have some active form of the drugs, and it makes them more specific that unless they reach that area, they are not metabolized. And also, while going there, because they are still in active form, they are not creating more side effects. So this is actually a good thing. So just remember, prodrug, that is a drug that's not yet active. It becomes active after passing through some stages of metabolism. Next question. Which of the following routes of drug administration completely bypasses absorption? A. Oral, B. Intravenous, C. Sublingual, D. Intramuscular. Yeah. So, in case of intravenous, so let's take one by one. In oral, when we take a drug orally, it passes through esophagus and then stomach and small intestine, large intestine, like that, right? So it starts being degraded right from the starting. In case of intravenous, we directly inject the drug into our bloodstream, that is in our veins. So it bypasses going to the liver and the GIT or anywhere. So it's 100% bioavailable. I showed this graph. Yeah, this graph. You see, in case of intravenous, this is, it start with the highest concentration of the drug, right? Cmax. And then it starts decreasing because it also follows um, first order kinetics. We'll discuss it when we'll discuss excretion. So yeah, just remember, intravenous, because it's injected directly into the bloodstream, it passes the first pass. um, so I'm sorry, we were in this question. Yeah. So intravenous drugs are directly injected into bloodstream, leading to 100% bioavailability. Other routes, oral, sublingual, and intramuscular, require some absorption before entering systemic circulation. Let's go to the next question. Which pharmacokinetic parameter describes total volume in which drug is distributed? A. Clearance, B. Bioavailability, C. Volume of distribution, or D. Elimination half-life. Uh, yeah, perfect. Yeah, it seems like you have gone through all the lessons. So, yeah, good. That's the correct answer. It's the theoretical value indicating how extensively a drug distributes into body tissue as compared to plasma. It's defined as the total amount of drug in the body divided by its concentration in the plasma. So, if there is high VD, the drug is extensively distributed to the tissue. But if it's low, that means the blood is mostly staying in the plasma and not being distributed properly. So, what's clearance? We've talked about bioavailability, volume of distribution now. Let's talk about clearance and elimination half life as well. So, clearance is a parameter representing. Okay, wait. Clearance is a parameter representing the efficiency of drug elimination. This is the rate of elimination of a substance divided by its concentration. The parameter indicates the theoretical volume of a plasma from which a substance would be completely removed per unit time. You know, um, it is sum of the clearance from liver, other parts, and kidney all together. So we'll talk about it more once we discuss elimination. Now, elimination half life is defined as the time it takes for the concentration of a drug in the plasma or the total amount of the body to be reduced to 50%. In other words, after one life, the concentration of the drug in the body will be half with what it was an administrated. So if we had like 100 mg of the drug, the time it would take for that drug to be 50 mg, that's called elimination half life. Next question. What does a high plasma protein binding of a drug indicate? A. High drug clearance. B. Increased free drug concentration. C. Low drug distribution to tissues. Or D. Increased bioavailability. Oh, sorry. A high. No, no, increased bioavailability, I think. Yeah, let me explain. So if the body if the plasma is so if the drug is binding too much to the plasma, it's less distributed. If it's less distributed, it might not reach to the target. So suppose if you have 100 mg of drug, okay, and if it binds to the plasma and it's not circulating properly in the body, so it might not reach 100% to the target. After being metabolized, it binds everywhere, so before it might not even be effective by the time it reaches the target. So that shows low drug distribution to the tissue. So drug that binds to plasma protein are inactive and they cannot cross membranes or exert effects. The only one that is like distributed, they have the high probability of reaching the target, and once they reach their target, they are metabolized, and after metabolism, they are excreted. High plasma protein, we discussed this in this case, right? So if it has high VD, that means the blood is extensively distributed into the tissue. If it has low VD, that means it remains mostly in the plasma. It has less tendency to roam around in the body, and if it's roaming less, it is working less, and it has lower probability of reaching the target and doing its work. Is that clear? Perfect. Next question. Which of the following correctly describes elimination half life of a drug? A. Time taken for the drug to reach peak plasma concentration. B. Time taken to eliminate 50% of the drug from plasma. C. Time required for 50% of the drug to be metabolized. Or D. Time taken for the drug to be completely eliminated. Sorry. Yes. Yeah, right. Because I just explained it in previous slide. It can be both, but yeah. Um, you are right. I have taken B as the option, but yeah, in my previous slide, I said from yeah from B and D as well. So you are right. Don't think about it. So um, here I've taken B because uh, half life is generally taken when we um, so we do not check the concentration everywhere. The easiest way for us to check is the plasma. So we just assume that if there is like 50% in plasma, that means 50% has been utilized, right? So it's an easier parameter to check. So yeah, half-life is a time required for the plasma drug concentration to decrease by 50%. It is influenced by VD and clearance. So T half is, if you remember the kinetics, 0.693 into VD clearance by half of by T half. So yeah, we'll come to the numerical part of it later, but at this point this is right. The drugs with long T half requires less frequent dosing. So T half along with VD, it helps us to get an idea of how the dosage should work. Which organ is the primary site of drug excretion? A, liver. B, kidney. C, lungs. Or D, skin. Yeah, perfect. Kidney eliminates most drugs via urine through glomerular filtration, tubular secretion, and tubular reabsorption. Liver helps in biliary excretion. Perfect. Next question. Which phase of drug metabolism makes drug more water soluble for excretion? Phase 1, oxidation, reduction, hydrolysis. B, phase 2, conjugation reactions. C, passive diffusion. D, active transport. It's actually the first one makes it makes the drug more polar, obviously. But when we talk exclusively in terms of excretion, when it's written there, because its conjugation happens mostly only for sulfation, acetylation, and methylation, so that the final product is easily excreted, more easily excreted. So when the question specifies more soluble for excretion, try to take B. Yeah, is there any question? Yeah, I don't think so. So yeah, but you're not wrong. I can understand, phase one is not wrong exactly, but because it's the question is focusing more on water soluble for excretion, the more appropriate answer would be B, phase two. Is that clear? Perfect. Phase 1 introduces functional groups via oxidation, reduction, and hydrolysis. This is also to make it more polar. But phase 2 conjugation reaction is like 100% to make it more soluble for excretion to be easier. Because it has to go through excretion, urine and or in form of bile. So, yeah. Last question. Which of the following statements about drug clearance, that is seal, is correct? A. It refers to the volume of plasma cleared of drug per unit time. B. It is the same as elimination half life. C. It depends only on renal function. Or D. It is not affected by hepatic metabolism. Drug clearance. Yeah. Yeah, sure. Let me see the slide where I think yeah. So, it is the rate of elimination by, so suppose, the theoretical value, so suppose you have something in the plasma. So it's the parameter in which you see how, so say 10% is removed from 100%. Like, suppose if you have like 100 rupees, and you say 10% discount, so it's 90% left, right? So 20% discount. Think about how it's cleared, you know in percentage. um, don't worry about it, because clearance, I think it needs more time, because I should mention more about clearance from, um, you know lungs. No, that's others. Lungs and muscles, they are from others, like hepatic and lung, liver and kidney. i'll I'll discuss this more clearly in the next class, if that's okay with you. Because then I remember putting some numericals for this one as well. I'll put it all together, and I'll discuss thoroughly the clearance topic, okay? Yeah, sorry. So let's move on to the next question. Yeah, I think you've already seen this last question. So let's discuss week 5 assignment solutions. So as I remember, the solutions have already been given. I'm discussing the square, these, yeah. Oh, half life, elimination half life. This is the same question as elimination half life. So, yeah, let's discuss that. What does a term half life in pharmacokinetics refer to? A. The time required for a drug to be completely metabolized by a liver. B. The time required by the drug concentration in plasma to reduce by half. Or C. The time taken for a drug to distribute evenly throughout the body. Or D. The time required for a drug to reach its maximum plasma concentration. This is the same as elimination um, you know, half life. No. Yeah, actually, you know, I think I brought this from a different assignment. So you can see it's question number 15, and this is question number 10. It was my mistake. But it's good of you to point it out. Sometimes people do skip it. Yeah. So, uh, so I know that the a solution for week 5 assignment has already been distributed. I'm discussing this just in case, you know, someone is struggling to find out how this is the correct answer and why not the other one. If you don't have any question, you can leave it. You can leave the meeting. It's very good for you, and thank you for such an interactive lesson. So, it was very good discussing all these things with you. So, if you have no problem with the week 5 assignment, yeah, you can leave it. I'll just continue this anyway. Okay, so let's discuss the first questions. Question: Once alkylated, Guanine prefers the enol tautomer and is more likely to base pair with thymine. True or false? So the answer was true because you can see here this is guanine. Once it gets so enol formation. So this is tautomerization. So it's keto and enol. So once this keto becomes enol, it becomes OH, double bond, and this OH. The this is the keto form. This is the enol form. So when guanine is alkylated, the modified guanine, that is, this one, ethyl guanine, is more likely to exist in enol form, this one, because this is much more stable for it. And once it becomes this, it it does not want to form base pair with the normal cytosine. It's more interested to form base pair because the OH will form like a hydrogen bond here, and it starts forming bond with thymine rather than cytosine, and this leads to mutation, because now the DNA polymerase will try to bind it with thymine instead of cytosine. So this leads to mispairing with thymine and hence mutation. So this is why this question it was true. The next question: diminished delivery of oxygen to tissue is termed as hypoxia, ischemia, homeostasis, or demetabolism. The correct answer here was hypoxia. Let's see what all these terms mean. Hypoxia refers to a condition where the body or a specific region is deprived of adequate supply of oxygen at the tissue level. It occurs due to various reasons like reduced oxygen supply to the tissue, low blood oxygen levels, or impaired oxygen utilization by cells. Ischemia is a condition where the flow of the blood to an organ is reduced. You know, it generally happens in case of cardiac muscles. It can lead to tissue damage, long time reduced supply of blood to an organ or muscle can lead to tissue damage and life-threatening conditions like heart attack and strokes. Homostasis, whereas means the body's ability to remain in an equilibrium, like our body's tendency to maintain a stable internal environment despite changing external environments by regulating physiological processes like temperature, blood sugar, and fluid balance. Now, last option was metabolism. Obviously, metabolism refers to the biotransformation of a drug within the body, primarily in by the liver, to convert it into less active or inactive metabolites for easier excretion. Yeah. The following antibiotic structure is an intercalating agent. What role does the ionic group serve to make this molecule an effective intercalating agent? So, see, yeah, sorry. You can see this is quite plainer, right? Intercalating, it means it puts itself in between something, and especially when we talk about DNA, it inserts itself in between the nitrogenous base pairs. So the options given were A, it increases water solubility, allowing high dose levels to be used. B, it interacts with charged phosphate groups in DNA to stabilize intercalation. C, it acts as a strong hydrogen bond donor with nucleic acid bases to stabilize intercalation. D, it only becomes protonated when it enters cell and so becomes trapped within the cell, leading to high concentration of drug. So it's quite obvious A and D has nothing to do with the structure of the drug. The interesting part here that we see is the charged, you know, NH3 positive. Now, we know the phosphate group is negatively charged. So once it is, we have a positively charged moiety, it it interacts with the negatively charged phosphate groups in the DNA and makes the intercalation more stable, right? Along with pushing itself, the planar structure pushes itself into, and once it gets to have like positive negative interaction, it becomes more steady and more stabilized, and it gets to hold into the structure and stabilizes the intercalation. That's why uh, B is more right. And in case of C, no, if it was some acid group or something like that, we might have thought about, or we might have considered the third option. But here option B is more accurate, so we answer B is the B is the answer. Saying 4. What is the molecular target for the vinca alkaloids used as anti-cancer agents? A. Tubulin. B. The transport protein for serotonin. C. DNA. Or D. Cell membrane. Is there anyone asking questions? Let me see. Nah, the correct answer was tubulin. So alkaloids like vinblastine and vincristin that disrupt cell division by binding to and inhibiting the polymerization of tubulin. The tubulin is a protein that forms microtubules, and it's very important during the cell division process and mitosis, which is crucial for cell structure and function, particularly during mitosis. Yes, it's written there. So vinca alkaloid mechanism, we'll discuss that. It binds to a specific region in tubulin protein, preventing it from polymerization, like coming together and forming microtubules. This leads to disruption in mitosis. By inhibiting a microtubule formation, it disrupts the mitotic spindle. It's unable to form mitotic spindle. That leads to cell arrest and ultimately cell death. Due to its ability to disrupt cell division, these alkaloids are used in chemotherapy, so that they arrest the cancerous and tumorous cells in their cell cycle, and to kill them, basically, the tumorous cells, including hematological and solid malignancy. The common examples are vincristin and vinblastine. These are the other two are not very common. The two most common are vincristin and vinblastine. The fifth one, pyridoxal phosphate and its aminate form, pyridoxamine phosphate, are tightly bound coenzyme of A. Aminotransferase, B. Glutaminase, C. Glutamine synthase, and D. Glutamate dehydrogenase. The correct answer given was aminotransferase, because, see, let's discuss. So let's discuss this briefly, and I'll show you the um, reaction. Pyridoxal phosphate, PLP, and PMP. PLP is active form of vitamin B6, and PMP is formed during transamination reaction. So as you see, it's transamination reaction. These enzymes, uh, so aminotransferases, they catalyze the transfer of amino group from amino acid to keto acid, and from keto acid to amino acid. So they basically transfer amines. That's why they are called aminotransferases or transaminases. During transamination process, PLP binds to enzyme and then undergoes a transient conversion to PMP as amino group is transferred. And it's crucial for synthesis and degradation of amino acid, neurotransmitters, and other molecules. Let's see the reaction here. Don't see the large molecule here, just see the difference in the first reaction and second reaction. The question clearly mentions pyridoxal phosphate and its aminate form. So sometimes the question itself gives an answer. If you don't even know about the reaction or anything, just read the question twice. Pyridoxal phosphate and its aminate form. So you would think there's addition of amine or transfer of amine in some sense. So just go through the options: aminotransferases, glutaminase, glutamine synthase, or glutamate dehydrogenase. You can see the most suitable answer here seems one. So even if you don't know everything and you would want to make a well informed guess, I would still encourage people to attempt this question and just take one, because that among the following options that were given, this one was the best option. Let's see in this reaction. So this is the reaction I was talking about. Just see this carbonyl group, aldehyde. There is addition of NH3 plus here, and this is the substrate amino acid. You see, it's amino donor. This is where the transferase, transaminase enzymes are involved. This is substrate amino acid. It becomes product oxo acid while adding NH3 plus here, and again from the substrate oxo acid you get product amino acid like this by this transforming into this and losing this one. So this is the main reaction. This is why the correct answer was aminotransferase. The next question: what role does ribosomal RNA play in the synthesis of proteins? It catalyzes the reaction. B. It provides genetic blueprint for the protein. C. It translates the genetic code to a specific amino acid. Or D. It modifies messenger RNA molecule prior to the protein synthesis. So we know there are different types of RNA, and these RNA have different roles to play during the synthesis of proteins, which is translation. Let's just look at role of different RNAs. So mRNA, RNA within the cell binds to mRNA. They're basically the first you don't even have to remember that. I discussed the process of translation quite in details in, I think, my second or third uh, problem solving session. If you'd like to have a brief recapitulation of what translation is, I would suggest you just go and see that, or maybe just see what translation is. You don't have to remember every part of it. If it's very good, I'll always encourage you to remember everything. But even if you don't, just remember mRNA has it has the genetic information. It is responsible for that um, that translation thing. I'm sorry. So tRNA brings the different opposite um, um, uh, oh god, I'm so sorry. tRNA, it carries specific amino acid according to the codon. mRNA carries the genetic information, and rRNA catalyzes the peptide bond formation during the translation. Yes. So, the catalytic RNA is rRNA because it catalyzes the peptide amide bond formation between the two amino acids, and it undergoes modifications such as methylation, which influences ribosomal functions and translation fidelity. That means like the correctness of the translation. And there's this interesting thing: tRNA sequences can be used to determine evolutionary relationships between species. Just remember that. So, yeah, the correct answer was one, it catalyzes the process. The second option is more correct for mRNA. The third is for tRNA. So, yeah. The next question is, which of the following molecule is not a nucleotide? Adenosine, adenosine monophosphate, adenosine diphosphate, and adenosine triphosphate. The correct answer is adenosine because that is a nucleoside. Nucleotide is nucleoside when it's attached with to a phosphate group. You can see when the base is adenine, the nucleoside here becomes adenosine, and deoxyribonucleoside becomes deoxyadenosine. So this is for nucleoside. Nucleotide is a compound consisting nucleoside linked to a phosphate group, and nucleotide form the basic structural unit for nucleic acids such as DNA or RNA. So nucleotides are also named as nucleoside monoditriphosphate. So this monophosphate is a nucleotide, diphosphate is a nucleotide, and triphosphate is a nucleotide, except adenosine, which is a nucleoside. So that's why the correct answer is adenosine. The next question was, which of the following statements is not true about DNA secondary structure? A. There is a minor groove and a major groove. B. Purine bases pair up with each other. C. The phosphate groups are positioned to the outside of the structure. Or D. The base pairs are stacked. The correct answer here, in this case, um, it's B, because purine base pair with pyrimidine. They don't form base pairs among themselves. Purine with pyrimidine always with purine. The secondary structure is all obviously helix or beta sheet. They do have minor groove or major groove. I'm sorry, I'll just have some water. And yes, the base pairs are stacked, due to the hydrophobic interaction. So, pu- suppose this is purine, this is pyrimidine, and this is pyrimidine, this is purine. They have like, hydrogen bond among themselves, maybe two, maybe three. They have like this cyclic rings. They stack among each other. So option 4 is correct. The phosphate groups are actually positioned outside the structure, because you can remember that there's a sugar group and the phosphate group. They form the backbone of the DNA structure, especially in case of alpha helix. So yeah, all the options are correct except the second one, which says purine base pair up with each other. No, purine always base pair with pyrimidine, and pyrimidine with purine. The next question was, metabolic intermediates found in living system which are essential for growth and life is called. So the keyword here being essential for growth and life. The correct answer was the correct answer given was primary metabolites. So let's discuss what saponins, tannins, secondary and primary metabolites are. The primary metabolites are essential, see, the keyword being essential, chemical compounds produced by organisms during normal growth, development, and reproduction. It plays crucial role in basic metabolic process and are often referred to as central metabolites. Saponins are diverse group of glycosides compounds with sugar moiety. They are called glycosides. They are found in plants and in some marine organisms, characterized by their ability to form, to form in water. So basically, make some kind of soap. That's why they get the name saponins. Tannins belong to larger group of compounds called polyphenols and are characterized by astringent and bitter taste. Their secondary metabolites are organic compounds produced by living organisms that are not directly involved in normal growth, development, reproduction, but often play a role in ecological interaction and can be beneficial to humans. So you understand the difference between primary and secondary. Primary are essential and they play crucial roles in basic metabolic processes, whereas secondary metabolites are not directly involved in normal growth. So that's why the correct answer was primary metabolites. The next question was what sort of reaction is catalyzed by a restriction enzymes in recombinant DNA technology? A. The hydrolysis of an ester group. B. The cleavage of sugar phosphate bond. C. The reduction of ketone. Or D. The formation of a sugar phosphate bond. So, restriction enzymes, they are the molecular seizure. So obviously they are not involved in formation. They cut the sugar phosphate bond. I've discussed this, I don't know, not in details though, but more or less in the session where we discussed replication, transcription, and translation. You can just look up restriction enzymes. They are very important tools in, so they recognize particular base pairs and they identify the sequences and they cut from there. And they also cut this sugar phosphate bond. So the correct answer is the cleavage of sugar phosphate bonds. Now this sir has discussed this quite thoroughly in his lessons. So the following antibacterial agent was used in Second World War. What is the name of the structure? So this is proflavin. Obviously, if you go through the lessons, you'll see sir has discussed this quite in detail and very thoroughly. So yeah, this is the structure of erythromycin, chloramphenicol, and rifampicin. So all these three, the structure is very different. This structure is proflavin. So yeah. The last question is what non-covalent bonding interaction do the nucleic acid bases form in DNA secondary structure? Non-covalent bonding interaction. Sorry, the what non-covalent bonding interaction do nucleic acid bases form in DNA secondary structure? Ionic bonds only, hydrogen bonds only, van der Waal interaction only. Last, hydrogen bonds and van der Waal interactions. The correct answer is hydrogen and van der Waal interaction, because when you say hydrogen bonds only, the bonds is only this hydrogen bond is between the nitrogenous base pair and you know, between COA and H. That's, not in this, but in protein. So the interaction that do stabilize, like, the nucleic acids, there is stacking as well, hydrophobic interaction there. So this makes the secondary structure more stable, and hence hydrogen and van der Waal interaction both make the DNA secondary structure more stable. So the correct answer was obviously both hydrogen and van der Waal interaction. So yeah, that concludes the problem solving session for today. If you have any question regarding, you know, the topics that are discussed today, or any question, I'll go through all the slides again. Just let me know if you have any question with uh, them, and we can discuss the question. I'll share all the slides again in my drive. The link has, you already have the link to my drive. I'll put this recorded session, I'll share the link as well. If you have any question, please do ask the questions. I might not be very good at explaining things, but I can always look it up and I'll try my best to explain. So, yeah, if there is no question, then this is the conclusion of our problem solving session for this week. I'll meet you guys in the next week and we'll discuss this week's assignment. See week 7 topics and some modular questions to help you, answer the assignment question or help you tackle the assignment questions properly. Again, if you have any questions, please feel free to ask the question even during the class. If not, you can just mail us, any of the tutors, and we would be glad to help you. Yeah. Yeah. Okay. So, the drive link is shared in the problem solving session. You'll see there's a link along with the recording. There's a link to there's a spreadsheet that NPTEL authorities share with you. I always update all the materials in my drive and I share this link. The link is same, I keep on adding things in the drive. It's so when I'll show you, wait. Just a second. I'll just show you. So when you log into your Swayam prod, you'll see there's a problem solving sessions recording. Just click on there, and once you click on there, you'll get a spreadsheet. You'll get a, I'll just show you again. Um, so this is week 1, week 2, week 3, week 4. So they, when you see problem solving session January 2025, there is this recording thing. You click on this, And once you click on this, there is this recording option. Click on it, and then you'll get the spreadsheet like this. This will have the YouTube channels in which we record all the session and share the link. This is my drive link. I keep on updating my drive with the latest PPT of just after the class. And yeah, so this is the drive in which you'll find PPT and the video recording of the channels. I hope this helps. If yeah, sure. Okay, so if that's it, do you have any question? Perfect. So I'll stop the share now. So thank you guys um, for joining the class. I hope you guys could, you know, understand everything that I taught. If you have any doubt, feel free to ask the questions. And yeah, I'll update everything in the drive and on my channel. Yeah. Okay. Bye. Good night.